All right, let's introduce ourselves. Assalamu alaikum. My name is Ibrahim Alodhaibi. I'm a fourth year medical student.
Hi guys, I'm Eman. I'm an intern.
And today we are going to be teaching you guys Hem-Onc pathology practice questions. So the way this session is going to work is that you guys are going to answer the questions and then we're going to explain. So
this isn't like last year. Maryam and I gave it last year. She did the benign hematology for an hour, and then I covered the malignant hematology for an hour. We've kind of mixed up the questions. It's going to resemble your exam a little bit more because obviously they're not going to split it up for you guys. So yeah, enjoy and stop us anytime you have any confusion about anything.
yeah, I'm just going to ask, can you open the chat here? Because I can't see it from here. All right, question number one. Does anyone want to read it, or should I just from now read every question? Like we both read the questions. I can't see the chat.
I'll open one
Oops.
second. Just give me 1 second.
I mean, no one said anything, so. I'm gonna read it. So a 60-year-old man presents with a 6-month history. Whoa. 60-year-old man presents with a 6-month history of increasing fatigue. Physical examination reveals pallor and a CBC showed macrocytic anemia. Which of the following is the most likely cause of anemia in this patient? So we have one answer.
So A, alcoholism, B, chronic disease, C, iron deficiency, D, renal disease, or E, thalassemia.
All right. All right.
Okay, so far, majority of the people inside the chat are saying A. Does anybody else have a different answer?
Who's here? Okay. Shall I reveal?
All right, so
The answer is drum roll. A. Oops. Yeah, the answer is A. Good
good
job.
job.
Now, my next question for you guys, and this is something very high yield, is how can we differentiate whether this is a vitamin B12 deficiency or whether this is a folate deficiency?
This is actually a pretty important concept that's also going to come in step 1 for those of you guys who are going to give it. Okay, so Riyuf is saying serum levels.
And
Nora
Nora
is
said,
saying neurological symptoms.
so that's correct, but serum levels, be more specific. What serum levels?
Neurological symptoms, Nora, takes time as well. So it's a later manifestation. Okay, Rushdan said MMA levels, correct. Excellent.
MMA levels in which deficiency though? In B12, exactly.
Good.
So
what's going to happen actually? Tell us the levels, like the level differences. Where is it increase, decrease, or normal?
it's increased
Increased
MMA and
MMA.
B12 deficiency.
Good.
Yeah.
And
what about homocysteine? Good. Yeah, it's increased.
And what about in B9? How is the MMA going to be? B9 deficiency, folate deficiency.
Yeah, folate deficiency.
Normal.
Yep.
Usually normal. Rarely low, but most likely it's in the normal range.
So
correct.
This is, yeah, you guys all got that concept. So just for like understanding sake, so MMA requires vitamin B12 in order to be converted into succinyl-CoA. So if you have a vitamin B12 deficiency, then you're not going to be able to convert MMA to succinyl-CoA, thus increasing the serum MMA levels. In vitamin B9 deficiency, that's not a problem. But vitamin B9, I believe, is needed to convert homocysteine to methionine. And that's why when vitamin B9 is not present, you'll have increased homocysteine levels. So everyone gets this concept of how to differentiate between the two macrocytic anemia causes, right?
Yeah. You'll see over here the tetrahydrofolate, the methylcobalamin, which is B12, so B9 and B12. So if one of them is missing, you can't complete this reaction. So homocysteine is going to be increased. And then same thing, like Ibrahim said for MMA.
We get it? Thumbs up.
Come on, guys.
Yes, okay.
Great.
Next question.
Okay.
Do you want to read it?
Sure. Okay, so a 20-year-old thin fashion model complains that she cannot concentrate and is always tired. She has heavy menstrual bleeding every month, but otherwise is healthy. The peripheral blood smear is shown. Which of the following lab findings would you expect to find in this patient? So A, hyperbilirubinemia, B, increased serum ferritin, C, low plasma iron saturation, D, positive direct Coombs test, or E, vitamin B12 deficiency. What do you guys think?
C,
Okay,
C.
so majority C's.
That was fast.
Yeah.
Oops. The answer is C. Yay. So this is a very basic iron
Straightforward.
deficiency anemia question. Like it's a thin young woman with heavy menstrual bleeding, so she's losing iron. I feel like this was important to include just because iron deficiency is so high yield, and you're
Mhm.
definitely gonna have a question similar to this on your exam.
Yeah. So you can note the hypochromia in the photo of the peripheral smear. So in case they don't give you more clues, you don't really need many clues. The only clue here really is heavy menstrual bleeding. You can just look at the peripheral smear and know immediately this is iron deficiency.
All right. Everyone was clear with iron deficiency, I'm assuming. So I'm going to move on to the next question. So there's a 36-year-old man from China who presented with increasing fatigue, and he has a 3-year history of tuberculosis. A CBC shows a mild microcytic anemia, and a blood workup demonstrated low serum iron, low iron binding capacity, and increased serum ferritin. The pathogenesis of anemia in this patient is most likely caused by which of the following mechanisms?
Okay, so you got
So
one
we only went
C.
C. I think that's everyone. How many people do we have? Yeah.
It's like around 5 people who answered, 6 people.
All right.
Yeah.
So the
Sounds
correct
good.
answer is C, as you guys said. Does anyone know what this is? Like, what's the diagnosis here? What kind of anemia is this? Yep.
Great. Anemia of chronic
Yeah.
disease. Good job, Rishdan.
Yeah, this is very important. The reason we put this question is because something very high yield in anemia of chronic diseases is the increased serum ferritin, because basically their body is unable to mobilize or like utilize iron that's already stored in the body. So they'll have increased ferritin. A lot of people remember anemia of chronic diseases as being normocytic anemia. It's not necessarily always true. Like in this case, the patient had microcytic anemia. So don't immediately rule it out if you see microcytic anemia. Like for an anemia of chronic disease question, they're usually going to talk to you about increased serum ferritin or give you a really long history of a chronic disease. So does everyone understand this question? Yes.
Great.
Awesome. And then here is just like a table that we brought for differentiating between iron deficiency anemia and anemia of chronic diseases. So iron is both or low, can be low in both. The total iron binding capacity will be high in iron deficiency anemia because the iron is the thing that's actually deficient, but they're still able to bind it. The transferrin saturation is going to be low in both, but it's going to be much lower in iron deficiency anemia. And then the ferritin, like I mentioned, will be high in anemia of chronic diseases.
All right. Okay. So 30-year-old woman complains of recent easy fatigability, bruising, and recurrent throat infections. Physical examination reveals numerous petechiae over her body and mouth. Abnormal laboratory findings include hemoglobin of 6, WBC of 1,500, platelets of 20,000. The bone marrow is hypocellular and displays increased fat. What is the appropriate diagnosis?
Nora, mashallah, answered before you even wrote it.
Yeah.
I think you knew from the picture.
Yeah. Again, if they literally just show you this picture and they're like, what is this? You guys can answer this immediately. It's very, very straightforward. And all of you guys have said A,
Yeah,
which is correct. It's
I
aplastic
said
anemia.
plastic anemia.
So just to quickly go over the normal values for hemoglobin, for men, if I'm not wrong, it is 10 to 15, 16. And then for women, it
I think
is,
men is 12 to
sorry,
14, and then woman is 10 to. You guys know this better than us.
anyway, it's just 2 less for women. WBC is 4 to 11,000, so 1,500 is obviously low. Platelets is 150 to 400,000, so 20,000 is very low.
And then this woman is low in everything. So she has aplastic anemia. Is there, okay, can I just,
If you see that alone, that itself is pancytopenia. So all your cell lines are low, which is a feature of aplastic anemia.
okay, now I just want to go over some causes of aplastic anemia, like just to, refresh your mind. So majority of the time, the cause of aplastic anemia is completely idiopathic. There can be genetic causes of aplastic anemia, like Fanconi's anemia, which is like a DNA repair defect issue in the child that causes increased cell death. It can be from medication. The most high yield one, I believe, is chloramphenicol. And it can be from infections like parvovirus or hepatitis, and then like chemotherapy, radiation, etc. Most commonly, it's idiopathic. Um, Basically, what happens is there's damage to the stem cells that are present in the bone marrow, and because there's damage to the stem cells that are present in the bone marrow, they're unable to produce
All the
any of the
cell
cell
lines.
lines.
Also benzene, gasoline.
High
So be
yield.
careful.
That's a high yield thing. You
It's a
might get a
toxic
question on
substance.
it later. So is everyone clear on? Let me take that. Yes.
Great. Okay.
Okay, here's the next question. Is it my turn to read?
Yeah.
4-year-old boy is brought to his pediatrician by his mother for recurrent nosebleeds, and the mother reported the boy has had 5 nosebleeds within the past 2 weeks, each lasting between 15 and 20 minutes. The patient was born at term and has been hospitalized twice for pneumonia treatment. There is no family history of serious illnesses. The patient is at the 8th percentile for height and the 30th percentile for weight. Vital signs are within normal limits. Examination shows small, thin child with 2 flat, dark brown areas of hyperpigmentation across the upper back and a small discoloration on the left buttocks. There's bilateral esotropia. Laboratory studies shows a hemoglobin concentration of 9.3, an MCV of 107, leukocytes 3,800, and platelets 46,000. Which of the following is the most likely underlying cause of this patient's condition? Oh no, I should be answered. I mean, someone answered before I even said it. Are you guys answering because you know the answer or because I showed it? We didn't see. Good.
Haha, sure. But good job, you guys are correct.
Yeah,
It is
so
a defect in DNA cross-link repair.
it's a Fanconi's anemia case, like Nora said. So just for any general refreshing, Fanconi's anemia is a genetic disease. It's more common in males. It's autosomal recessive usually, rarely it can be X-linked. You're gonna see in a question case about Fanconi anemia, like a multitude of abnormalities on the physical exam. And you saw that in this question, he had the discoloration and he had the esotropia. They're gonna have empty bone marrow and a bone marrow aspiration, like similar to this picture. They'll have pancytopenia, obviously. And the reason it occurs is because there's a defect in DNA cross-linking repair. And because there's that defect, there's going to be more DNA error, which is going to cause instability and cell death, and thus you can't form the cell lines. So that's Fanconi's anemia for you guys. Next question.
All right, so the next question. A 10-year-old boy presents with chronic fatigue. Physical examination reveals slight jaundice and splenomegaly. Results of lab studies include hemoglobin of 11.7, hematocrit of 32%, total bilirubin of 2.6, and conjugated bilirubin of 0.8. The peripheral blood smear is shown in the image. The osmotic fragility of the patient's RBCs is increased, but the Coombs test is negative. Defects in which of the following are involved in the pathogenesis of this disorder? So what here is your key information, like your one-liner? Okay, you guys all answered already.
Everyone answered that.
Okay, great. So all of you said B, which is precise cytoskeleton, which is correct. So what is this? Good, hereditary spherocytosis. You guys don't even want to write the whole thing.
Rushdan, yeah, the keyword here was the high osmotic fragility in the test.
You guys could literally forget about everything else, but I mean, don't forget about everything else. The reason the bilirubin is high is why? Correct. Due to hemolysis. Perfect. All right, so you guys pretty much get this concept. Are you guys okay with us moving on?
Oops. Next question is, what mutations could you see in this patient that has hereditary spherocytosis?
Nice. So you said anchorin.
Anchorin. What else?
Spectrum.
Yes.
Band 3.
And 4.2. Yeah.
Then you are either reading off of something else or you studied really, really well.
Mashallah.
Yeah.
Yes, anchorin and spectrin are the more high yield ones. Band 3 and 4.2 are also, they're also mutated, but the more like common high yield ones are anchorin and spectrin. So here's just like a little visual of what's happening in hereditary spherocytosis. Basically, what happens is either the anchorin or the spectrin is defected, and then you're not able to, the lipid bilayer of the RBC is not able to form properly. And so when going through the spleen, splenic macrophages are going to like eat at the cells and then cause them to have this like sphere shape. And this is not good for the cells because they shouldn't be that shape. It should be like that. A little
biconcave.
There, that's the word. Next question. Oh, no, actually, this is just another random review thing. Just general like knowledge you guys should know for any question. What are the signs of hemolysis? So in this, like the destruction side of hemolysis, the signs would be there'd be more bilirubin, and we mentioned that's happening because of hemolysis already. It would mostly be unconjugated bilirubin and like mass hemolysis because the liver is not going to be able to keep up with conjugating if there's a hemolysis going on all the time. There's going to be increased LDH, which is an intracellular enzyme found in RBCs, and there's going to be decreased haptoglobin. This one is like a key thing important. They say this a lot in questions because haptoglobin binds free hemoglobin. So if there's decreased haptoglobin, that means there's a lot of free hemoglobin, which means hemolysis is happening.
Mm-hmm.
Signs of production, you're going to see more reticulocytes because the bone marrow is pushing things out faster in order to keep up with the body. And you're going to see same idea, nucleated red blood cells, same concept. The bone marrow is pushing things out to keep up with the body.
So your bone marrow is getting a signal basically from your blood that, oh, hey, we have a low cell count, specifically red blood cell count. But that doesn't matter. They're not going to start all of a sudden like increase erythropoiesis immediately. So the fastest thing is to just push out the immature RBCs that they have, which are the reticulocytes. All right. You want to read it?
Isn't it yours?
Sure. A 10-year-old Black girl is brought to the emergency room. She complains of severe pain in her chest, abdomen, and bones. Physical examination reveals jaundice and anemia. Her parents state that she has been anemic since birth. A CBC shows normocytic anemia with marked poikilocytosis. A peripheral blood smear is shown in the image. Hemoglobin electrophoresis demonstrates hemoglobin S. This child's chest and bone pain is most likely caused by which of the following mechanisms? A, amyloidosis, B, coagulopathy, C, infection, D, ischemia, or E, vasculitis. All right, so you got 3 people saying D.
Answers.
Participants. It's just 9 people still.
D. What else?
Anyone have a different answer?
What is this? What does she have? Yep.
Nice. Perfect, guys. Good job. So you guys are correct. It is ischemia. So one thing to know about sickle cell. Okay. If the question was, what is the pathogenesis of this patient's disease? What would you guys say?
Back to high school.
I don't know if they're typing or if they're
glutamic
2-valine. So good job, Noda. So it's glutamic acid 2-valine in position 6 of the beta globin gene. Why is that bad? Insolubility of HB, good. Okay, perfect. So glutamic acid keeps it hydrophilic, whereas valine, because it has no charge as opposed to a positive charge that glutamic acid has, it's hydrophobic. So instead of basically staying like repelling each other, the cell collapses and it forms a sickle cell shape, and therefore it starts to sequestrate in your small vessels, and then it causes ischemia. If this was a male patient, sorry, just getting a phone call. Okay, if this is a male patient, one of the other signs that they can have is priapism. So priapism is basically when their penis stays erect and they cannot get it down. It's very, very painful. So if you have that in another, like, as one of the descriptions in a question, that can also be sickle cell disease.
Also, memorize this picture.
Yeah.
This is like the sickle cell picture.
Mm-hmm.
Every sickle cell anemia question is going to have something like this. Next question. Okay. So a 2-year-old woman from a large Italian family is screened for familial blood disorder, and the result of the laboratory study includes a hemoglobin of 9.5, and a smear displaying displaying microcytosis, hypochromia, and a few target cells. Hemoglobin electrophoresis showed a mild increase in hemoglobin A2, 7.5%. What's the appropriate diagnosis?
Okay, so we've got one Z, one Z, one
I was
C.
gonna say Z2. I don't know why. C.
I read heterozygous.
C. C. C.
C.
One more answer. We'll wait for one more answer. Okay. The correct answer is C.
Whoa. Woohoo.
So, do you want to explain this one?
No, you can go ahead.
No, can you explain it?
Okay, sure. So in beta thalassemia, what's happening is you have decreased or dysfunctional production of your beta hemoglobin chains. So what happens is it basically, what's the word? Compensatory. Anyway, for compensation, there's increased alpha chain production, which is what you guys see over here. So there's a mild increase in hemoglobin A2, alpha 2.
And then here's a table from Amboss. This is like a sacred table now because nobody has access to Amboss anymore. But here's a table about the different thalassemias.
Yeah.
Honestly, I recommend that you guys know this very well because there's so many ways they can ask you thalassemia questions in the exam. You're gonna at least get like 2, I think.
100%.
Probably an SAQ on thalassemia.
Mm-hmm.
So make sure you understand it very well. Make sure you know the different types, the traits. If I remember correctly, I think we got a question last year where they actually like asked us to write the genes, like the dash dash alpha dash, like that stuff. So make sure you know that well.
Yeah. Know that. I'm gonna point out the keywords that they want you to remember that are gonna come in your question. So let's start from alpha. It's on top anyway. So hydrops fetalis is super, super important. So as soon as you see hydrops fetalis, you're going to say hemoglobin Bart's disease, okay? That means all 4 defective alleles. Now in beta thalassemia, notice over here how it says mild increase in hemoglobin. That's why you're able to say heterozygous beta thalassemia. But if there's a higher increase in hemoglobin alpha, that means that both beta globin genes are kind of knocked out or dysfunctional, and therefore there is higher compensation by alpha chains, sorry. So you're going to have a greater increase of hemoglobin alpha 2. Is that clear to you guys? Perfect.
Awesome. Moving on to the next question. Just kidding. Let's I forgot. Well, just general stuff about thalassemias. Like Eman mentioned, if you have defective beta globin chain synthesis, then you're gonna compensate and you're gonna make excessive alpha chain. This is gonna cause membrane like damage in the cell membrane. And the bone marrow side of things, you're gonna have ineffective erythropoiesis, which is gonna cause anemia. And you're gonna need like blood transfusions. You could get iron overloads, which could cause death. Like there's complications on the blood transfusion side of things. And the actual cells circulating in thalassemia, there's gonna be hemolysis because the cell membrane is messed up. And the erythropoietin is going to be increased because you're going to try to produce red blood cells as much as possible, but you're not going to be able to produce them properly because you have the defective gene. And then you're going to have bone marrow expansion. That's going to cause the thalassemic phases, and you can see in like the like in the x-rays as well, you're going to see like the hair end appearance of the skull. All of those things are happening because your bone marrow is working so hard to try to make new stuff, and you're going to have hypermetabolism as well, and that has its own complications. Next question for real. I'll read it.
Yeah.
A 60-year-old man presents with headaches and pruritus, and a physical exam revealed splenomegaly but no lymphadenopathy. A CBC demonstrates elevated hemoglobin of 19.5, WBC of 12,800. I should not have emphasized the hemoglobin. I gave it away. And platelets of 550,000. The bone marrow displays hypercellularity of all lineages and depletion of bone marrow iron stores. Which of the following is the most likely diagnosis? I wish I shouldn't have emphasized the hemoglobin. Okay. E. What else? One more answer. There we go. Correct. It's polycythemia vera. So, what is this patient at an increased risk of developing? DVT. That's true. Anything else?
Think simple. Like you have a lot of cells. Whoa, leukemia?
No, not liver infarct, maybe a liver infarct actually, but I don't think leukemia. But think like something that will cause death that's like really like it's a simple thing. Don't overthink this. What are they increased? If you have blood vessels that are getting clogged up, what's something that could like instantly cause death? Think neuro. There, a stroke, exactly. Cerebrovascular accidents.
Yeah.
That's what I was looking for. A lot of these patients with polycythemia vera can present with these because the increased hemoglobin in the blood and basically the super thick blood it wasn't mentioned. That's okay. I mean, these kinds of things you want to think it through. Like, okay, if my blood vessels are getting occluded by all of these things, what might be happening? You know, I feel like that's what third year is about, is thinking your way through things because they can't mention everything. But good, you guys got to the answer. Anyways, yeah, these patients are at increased risk of developing cerebrovascular accidents. By the way, a lot of the things you guys said is correct. Any renal diseases, liver infarcts, all of those things. So let's talk a little bit about myeloproliferative disorders. So they are associated with JAK2 mutations. So if you ever see a question with JAK2 like mentioned somewhere, you should immediately start thinking about myeloproliferative disorders. They're divided into these four things. They're divided into chronic myeloid leukemia, polycythemia vera, which was just the question on, essential thrombocytosis, and myelofibrosis. I think the two highest yield ones here would be CML and polycythemia vera. And usually what's happening is that this is actually an acquired mutation, so they're not born with it, in the stem cells, usually due to like secondary to like radiation that they've been exposed to. Can't it progress to AML from CML? It can. Yeah.
Definitely.
So that's myeloproliferative disorders. Are we clear on like the four? Just make sure that you're not mixing up, because I think the difficult thing in heme is that there's so many like names of diseases. So make sure you're splitting them up by category in your head. Like I know, like keep CML a little bit separate from the other leukemias because it's a JAK2 mutation. It's myeloproliferative disorder category. We're good with that.
Great. All right. A 60-year-old man complains of night sweats, weight loss, easy fatigability, and discomfort in the left upper abdominal quadrant. Physical examination reveals splenomegaly. Lab studies show leukocytosis, so 40,000. Normal is 4 to 11,000. Peripheral blood smear demonstrates mature and maturing granulocytes, myelocytes, basophils, and occasional myoblasts. The bone marrow is hypercellular and dominated by white blood cell precursors. Megakaryocytes are numerous and RBC precursors are less prominent. A smear of the bone marrow aspirate is shown in the image. Cytogenetic studies disclose a monoclonal population of abnormal cells with a 922 chromosomal translocation. What is the appropriate diagnosis? Okay, so immediately everyone has said D. Chronic myelogenous leukemia. All right.
You're all wrong. I'm kidding. It's CML. You're right. I think this kind of question kind of gave it away when we put the chromosomal mutation. But to be fair, you wouldn't know what it is without the chromosomal mutation. They'll usually give you this.
But you could guess.
You could guess, but usually, especially in heme onc, you're going to be given. That's why you really need to know your translocations well, because this will like make or break if you know a question.
You could guess based off of maturing granulocytes, myelocytes, basophils, and myeloblasts, because all of these cells, although some immature and mature, are all from the same progenitor cell, which is a myeloid cell. And if you have 40,000 and this has been chronic, you can say this is most likely chronic myelogenous leukemia. You confirm your diagnosis by doing or checking the chromosomal translocation. That's at least how it happens in the hospital. So if you didn't have the translocation, you can tell, okay, this is most likely myelogenous leukemia based on the number, because it's not higher than 40. And based on the types of cells that are predominant, they're all myeloid cells and they're at different stages. You can say this is chronic. You're not going to see as many mature cells in acute myelogenous leukemia because they're so rapidly dividing. Majority of them are more immature. Does that make sense? Great.
All right. Now a little crash course on CML, because it's high yield. You're going to have, like we already mentioned, there's going to be the translocation between chromosomes 9 and 22, sometimes called the Philadelphia chromosome. And you're going to get the formation of the BCR-ABL gene, which is going to lead to uncontrolled tyrosine kinase activity. And you all passed mole, so you should know what tyrosine kinase activity is. Now, acute and chronic, the main way to differentiate between acute and chronic myeloid leukemia is by the number of blast cells. So if the number of blast cells is greater than 20% of the total number of cells, then you can call it an acute myeloid leukemia. But if it's less than 20%, then you can call it chronic myeloid leukemia. So in this patient, they didn't give us the number of blast cells, but this was a chronic myeloid leukemia, so he had less than 20% of blast cells. Features of CML would be splenomegaly. You're going to see cells at all stages of development. So like here in this question, they said like or maturing granulocytes, myelocytes, basophils. So they're all at different stages of development. And then another thing that's kind of unique to CML is the basophilia. I don't know how much this actually translates in the real world, but in questions,
it does.
Okay, well, there's your answer. But in questions, basophilia is usually like a keyword for CML. So keep that in the back.
If you guys remember from first year, in your HLS questions or HLS lectures, actually, Dr. Rehan, I remember there was this one slide where he was like CML, basophilia, basophilia, basophilia. So that's how important it is of a point. So if you see basophilia, just assume CML until like a question stem tells you otherwise.
Moving on. So diagnosis, there's two ways that you can diagnose this. You can do a bone marrow aspirate to check for the Philadelphia chromosome, or you can do a molecular test and do PCR to check for the BCR-ABL translocation. Now the phases is actually important. This is an easy SAQ for them to give you, by the way. So the chronic phase is when the blood and bone marrow blast cells are less than 10%. The accelerated phase is between 10 and 19%, and then the blast phase is when it's greater than 20%. Now, if the blast cells are lymphoblasts, you can call it acute lymphocytic leukemia. If the blast cells are myeloblasts, you can call it acute myelocytic leukemia. The treatment, because this is a tyrosine kinase uninhibited activity, we're going to give them a tyrosine kinase inhibitor like imatinib or nilotinib.
They also have more nowadays, but you guys don't need to know that until 5th year. But just remember, IB means inhibitor, AB means antibody, because I know you guys probably saw both because you learned also about like multiple myeloma, which you use an antibody for, not an inhibitor for. So keep that in mind.
And now another SAQ that
I think this came for us actually when I was in 3rd year.
I think it came for us too. I don't remember.
Make sure.
But the remission of CML, there's 3 definitions for remission in CML. There's the hematological remission, which is when the patient's CBC becomes normal. There's the cytogenetic remission, which means that the patient no longer has any Philadelphia chromosomes. Or there's the molecular remission, which is a 1,000-fold decrease in the BCR-ABL transcript. The 1,000-fold is important. Like if they ask you this, you have to say 1,000-fold or 3 log decrease in BCR-ABL transcript. All right, so we...
Do you guys have any questions about that, CML? We're both pretty good at CML actually, so we can explain this all day to you if you want.
All good?
Great, nice.
All right.
Okay, this is something that I created when I was doing my hemonc rotation last year, but it is applicable to both 5th year and 3rd year. Okay, so this is about the hematologic malignancies that you guys are going to see in your blocks, but I basically made a quick mind map and I don't know how to show it as a picture, and anyway, as a picture, you wouldn't be able to see it. So, blood cancers, you guys know that you have leukemia and lymphoma, and sometimes there's a confusion of like, what's the difference in terms of where they're coming in the body. Leukemias originate in the bone marrow, lymphomas in the lymph nodes. So let's go for leukemias first. You've got 2 types, myeloid and lymphocytic leukemias, okay? So from your myeloid, you've got your acute and your chronic. For lymphocytic, acute and chronic, pretty straightforward. So the first thing is like location. So leukemia, bone marrow, leukemia. There's 2 types, myeloid and lymphocytic. And for both, there's acute and chronic. So let's look at the myeloid, acute and chronic first. So for the acute, obviously there's like quite a few things that you need to remember. Forget about this. But there's acute myeloid leukemia. You have unfavorable translocations and favorable translocations. Then you have acute promyelocytic leukemia, which is specifically T1517, PML-RARA, which is basically an issue in your retinoic acid receptor alpha. And you treat it with ATRA, all-trans retinoic acid, and sometimes they even treat it with arsenic trioxide, okay? Generally, AMLs, they're MPO positive, CD13, 15, 16, 33, and 65 positive. You don't need to remember all of these. Remember the ones that they highlighted in your lectures, okay? But typically from what I remember, 15, 33, 13, those ones are important. Now for chronic myeloid leukemia, as we said it like a bunch of times in the past 5 minutes, it's a 9 to 22 translocation known as a Philadelphia chromosome translocation. It's a BCR-ABL fusion protein, which causes increased tyrosine kinase activity. So you treat it with TKIs, tyrosine kinase inhibitors, okay? Then in your lymphocytic, you have acute lymphocytic leukemia, which is, do you remember what that stands for?
TDT positive. I don't remember what it stands for.
I'm so sorry, guys. We should be better than this, but TDT positive. You're gonna see it immediately. T-deoxy. Somebody say it in the chat. I'm sure one of you know it for sure. You guys know everything so far, so. But anyway, TDT positive. Then you have your chronic lymphocytic leukemia, which is CD5, 19, and 20 positive. This is very important.
It's terminal deoxynucleotide transferase.
Thank
You don't
you.
need to know what it stands for.
Yeah, just remember TDT positive. And then that has its own treatments. Now, for the other side, for lymphomas, which originate in the lymph nodes, that's what makes it a lymphoma. You have Hodgkin and non-Hodgkin. Main thing you guys need to know about Hodgkin lymphomas are the Reed-Sternberg cells and that they're 15 and CD30 positive. You have lymphocyte rich, and you have lymphocyte depleted. Lymphocyte depleted is a poor prognosis. Lymphocyte rich is a good prognosis because you can actually see the lymphocytes, meaning that there are like proper mature white blood cells present, okay? Maturity is usually always a good sign of, like in terms of prognosis, it's a good sign. Now it has its own treatment. I don't know if they want you guys to go over the treatment, but I'm not going to go over it for now. If you guys have to go over it, you can go over it yourselves. It's pretty straightforward in my opinion. Ask those questions later if you do need to though. For non-Hodgkin's, you have B cell and T cell. So B cell is CD20, T cell is CD3. So basically the CD markers, 10 above, we consider them like big numbers. So B cells, below they're tiny T cells. We have that coming in a slide as well to remind you guys. But for the B cells, you've got low grade, high grade. For the low grade, you've got follicular, hairy cell, marginal zone, Waldenstrom macroglobulinemia, which you guys have seen all of these by now. So follicular is T1418, hairy cell is trap. Think of something getting trapped in your hair. That's how I like to remember it. Marginal zone is 11 to 18, and it's also associated with Helicobacter pylori infections, which cause stomach ulcers. And then Waldenstrom macroglobulinemia, you can ask me to this day. It came on my step 1. I still do not know what it really is exactly, but yeah. But it comes with multiple myeloma. You can remember it that way. IgM antibody production. Then in high grade, you've got diffuse DLBCL, which is BCL2, BCL6, and P53. Mantle cell, which is 11 to 14 and CD5 positive, it's increased cyclin D1. And in Burkitt's, which is 8 to 14, c-MYC, this is the starry sky appearance. Okay. And then over here in your T cells, honestly, you guys are really not going to see a lot of this. So that's why it's also at the bottom over here. But mycosis fungoides, Sézary syndrome, if you guys have to remember these come under the T cell lymphomas, okay? All right, so this is shared with you. You guys have access to this if you guys want to go over it. But yeah, that's just to quickly give you a mind map before we see more
lymphoma leukemia questions. Hold on.
Okay.
Yes. We answered this question? No.
Okay.
Okay, a 46-year-old man presented with ataxia and MRI shows cerebellar infarct. The platelet count is discovered to be 955,000. The bone marrow biopsy reveals increased megakaryocytes with absent fibrosis, which is shown in the image. Cytogenetic studies are normal. Which of the following is the most likely diagnosis? You all have to answer this question.
Every single one of you.
You saw it.
Oh, Rashdan, we understand your confusion. Good. Okay, so
more answers. There's more of you. Or did the lymphoma stuff scare you guys away? Yeah, the answer is B.
Nice.
This is essential thrombocythemia. Never can pronounce it. Basically, this guy just has increased platelets. You can see he's having an infarct because of all the increased platelets aggregating likely. You can see that he has a ridiculously high platelet count. And then what really makes you think that this is essential thrombocythemia is that he has increased megakaryocytes. So like here you can see these like big cells here are all megakaryocytes in the bone marrow. So that means he's got a lot of activity going on that's making platelets. What's important about essential thrombocythemia, is that it is a diagnosis of exclusion. And so that's why in this question stem, they told you that all the cytogenetic studies are normal, which means that they ruled out any other possible thing that it could be. And the only cause of this platelets is essential thrombocythemia, which is basically just them kind of saying, we don't really know what's going on, but they've got a lot of platelets. Okay, next question.
All right, okay. 68-year-old man comes to the physician for evaluation of a lump in his left axilla that he noticed 1 year ago. He reports that the size of the mass has varied over time and that there have been similar masses in his neck and groin. He has not had fever, weight loss, or night sweats. Physical examination shows a non-tender rubbery mass in the left axilla and a similar, smaller mass in the right groin. His spleen is palpable 3 centimeters below the left costal margin. Lab studies, including CBC, are within reference ranges. Genetic analysis obtained on resection of the axillary mass shows a T14 to 18 translocation. So which of this is the most likely diagnosis? A, Hodgkin's lymphoma, B, follicular lymphoma, C, diffuse large B-cell lymphoma, D, Burkitt's, or E, mantle cell. Okay, so Firal said
3
B.
Bs, 4
Firal
Bs.
said B. No, I think that's from the previous question.
Oh, 3 Bs.
Firal said B.
What else? This is how your lymphoma questions are gonna look.
One thing about Heme Onc is I've noticed in PALS, we never have to really argue over answer choices like we do in like CVP or renal, which is so nice.
You guys are right. It's
Yeah.
follicular lymphoma. So I'm about to show you guys the world's stupidest mnemonic. It's actually ridiculous, but for some reason it really helped me with lymphomas. So basically, and bear with me because this is going to be more confusing than me explaining lymphomas, is you have to draw a triangle on paper, okay? And then this side of the triangle has to be at the margin of the paper, okay? And then the top of the triangle is the mantle of the triangle. and then you put the numbers like they're in clocks. So like how it is like in like a clockwork, like in order. So 11, 14, 18, right? And then you can draw the arrows to know that this like the margin would be 11, 18, the mantle would be 11, 14, and then the follicular, which is the only thing that's left, would be 14, 18. Okay. And then Burkitt's starts with a B, and B kind of looks like a B, right? And it looks like an 8. And so Burkitt's lymphoma could be 814. I know that this is so confusing to understand, but I promise you, if you sit and look at this picture for a little bit and then just shove it in your short-term memory, as soon as you sit down in the exam, draw it, you won't mess up the translocations. Like this really actually helped me in Heme Onc a lot. Do you guys get it?
What about 15, 17?
This is not for everything, but this mnemonic needs a mnemonic. I mean, listen, just look at the picture.
Mnemonic needs a mnemonic.
It's so I'm embarrassed. Look at the picture, try to understand it. It really helped me because also personally for me, these were the 3 lymphomas that I forgot the most. Like marginal, mantle, and follicular. I feel like I was gonna say nobody cares about them. No, but they're just like I didn't remember these ones well. So this is what helped me a lot.
Yeah.
I'm gonna move on.
Okay. Do you want me to read it?
Yeah.
Okay. A 27-year-old man. Wait, did you guys get that? Do you have any questions?
I could explain the mnemonic more at the end of the session to those who are interested.
All right, no
And
one's saying anything,
nobody's
so I'm just
interested.
gonna move on. Okay, so 27-year-old man presents with an 8-week history of fevers, chills, pruritus, and night sweats. So itchiness and night sweats. 2 months ago, he experienced a flu-like illness, nagging cough with occasional hemoptysis, persisting for several weeks following resolution of his other symptoms. Physical examination reveals moderately enlarged, firm, non-tender lymph nodes located in the right supraclavicular region. A lymph node biopsy is shown in the image. Which is the appropriate diagnosis? Guys, come on, give me a chance to read the answers. Okay,
They
so
got it. It's
majority of you
Hodgkin's.
saying C, Hodgkin's, correct.
Yeah, it is
It's okay.
Hodgkin's.
You guys are right. So even if you don't get it from the question, you don't necessarily get it from the question, but immediately you see that image, you see the 2 eyes, they're staring right at you. That's a Reed Sternberg cell.
And then these are the owl eyes, I think they call them. So the way you can remember C15 and 30 is that there's 2 eyes. 15 times 2 equals 30. CD15, CD30.
This is like your triangle all over again.
That one makes sense to me. Okay, maybe my mnemonics don't work. I don't know. But that's Reed Sternberg's. Okay, next question. Moving on. A 4-year-old boy from Kenya presents with a 3-week history of rapidly expanding jaw, and a biopsy of an enlarged cervical lymph node is shown in the image. Histological examinations reveals numerous mitotic figures and many macrophages containing nuclear and cytoplasmic debris. The cells express surface IgM and are positive for common B-cell antigens. Which of the following is the appropriate diagnosis?
This is good that you guys are getting it immediately, even before we're finishing, by the way. This is a very good sign. Because a lot of your questions are going to come like this level in the exam.
It's going to be this level, and a lot of your questions are going to have a picture attached to it. And if you can just get it from the picture, it'll make your life so much easier.
You might, in all honesty, get a few low yield questions, but yep. Expanding jaw, yes, Burkitt's. It's most likely Burkitt's.
Yes.
Because no other hematologic malignancy, at least from our knowledge, causes jaw expansion like this. Also demographic, so it's a young boy, it's a pediatric patient from Kenya. Yeah, so good job, guys. It is B, Burkitt's lymphoma.
Yay.
All right, I can read this if you'd like.
Yeah, go ahead.
Okay, a 12-year-old boy is taken to the physician because he has had increasing abdominal distension and pain for the past 3 days. Physical examination shows lower abdominal tenderness, abdomen is tympanic with reduced bowel sounds. A CT scan shows a 7-centimeter mass involving the region of the ileocecal valve. Surgery is performed to remove the mass. Histologic examination of the mass shows sheets of intermediate-sized lymphoid cells, with nuclei having coarse chromatin, several nucleoli, and many mitoses. A bone marrow biopsy sample is negative for the cell population. Cytogenetic analysis shows a T8 to 14 karyotype. Flow cytometric analysis reveals 40% of the cells are in S phase. They already answered. The tumor shrinks dramatically in size after a course of chemotherapy. Which of the following is the most likely diagnosis? So Rushdan said E, Arwa said E. Does anybody else have any other? Okay, Noor said E.
2 more E's.
Said E.
We thought it would trick you if we put two Burkitt's questions back to back, but no, seriously though, the reason I wanted to bring this question is because this is not like a typical case of Burkitt's. Like you're not getting the jaw expansion. They talked more about like the mass involving the ileocecal valve. Also, they didn't show you the starry sky appearance. They described it. So like just kind of understand how they would describe the starry sky appearance, because a lot of times in hematology or like any histology related thing, they can just describe the picture instead of giving you the picture. So you should know how the picture will be described. And then 814 immediately gave it away that this is Burkitt's lymphoma. Yeah. All right. 53-year-old man comes to his physician because he felt a lump near his shoulder 1 week ago. On physical exam, there's an enlarged non-tender supraclavicular lymph node and enlargement of the Waldeyer rings of the oropharyngeal lymphoid tissue. There's no hepatosplenomegaly. CBC is normal except for findings of mild anemia. A lymph node biopsy shows specimens. A lymph node biopsy specimen shows replacements by monomorphous population of large lymphoid cells with enlarged nuclei and prominent nucleoli. Immunohistochemical staining and flow cytometry of the node indicates that most lymphoid cells are CD19 positive, CD10 positive, CD3 negative, CD15 negative, and TDT negative. Which of the following is the most likely diagnosis? Hold on, I don't remember the answer to this question, so I'm going to try to remember it.
Okay, I remember it. So
I think they're right.
Okay, so Rushdan, Firas, and
Yeah.
Arwa said B. Nora said B. Anyone else have any other answer? Feel free to get it wrong if you guys want. Like, I know no one wants to, but
It's okay.
this is where you get it wrong so you don't get it wrong in your exam.
All right.
Okay, so you guys are correct.
Correct.
It is diffuse large B-cell lymphoma. You can think of that and go back for a second.
Oh.
You can think of that in the age, and in the involvement of the lymph nodes, and also CD19, CD10 positive. These are B-cell markers, so that will automatically take out lymphoblastic lymphoma, small lymphocytic lymphoma, most likely. Actually, no, never mind. Sorry, I was confusing that with T cells. Never mind. But anyway, CD19, CD10 will tell you B cell for sure. And you guys know diffuse large B cell lymphoma is usually like the most likely answer because it is the most commonly tested one out of the lymphomas.
And then to Noura, who said that no, she confuses diffuse B cell with follicular. It is confusing. A lot of the lymphoma questions can be really confusing. You're just going to have to look at the thing that differentiates each lymphoma. So for follicular, they're going to give you the translocation. Like they're going to give you 1418. All right. Like especially at your level, you're going to get the translocation so that you know which one is which. All right. Here, they gave you for sure that this is a B cell lymphoma because of the CD markers. And that's kind of what gave it away, that this is a diffuse B cell lymphoma. You could eliminate everything else.
Or sometimes what they will do is if they don't give you the translocation, they will give you the histopathologic slide. And you guys are going to be asked what the translocation is or what the diagnosis is. That's usually what I've noticed. Or the pathogenesis.
They can get creative.
Yeah. So just know it from all angles. Okay, that's like the main takeaway. So like I mentioned earlier, the CD markers, you've got your B and T. So the way to know is B, big, so bigger than 10. So B cell markers are going to be greater than CD10. So CD10 and above. T cells, T for tiny. So they're going to be tinier than 10. So the number is lower than CD10. So CD3, CD5, etc.
I'm going to emphasize now how important it is for you guys to remember your CD markers. I know this list is like ridiculous and redundant and so long, but knowing your CD markers is going to help you answer the questions. Make an Anki, make a Quizlet, do whatever you need to do to memorize which CD markers correlate with what, especially this one on the left corner here, because they're just going to give you the CD markers in a question, and it's going to be one of those questions where you either know the answer or you have no idea what they're talking about. So know the CD markers because it's going to give you a free like 5 questions. And don't panic if you don't know them well yet. You still have 2 days. You can memorize them in like an hour. Max.
Yes, that's so true. Remember, I did this the night before the exam.
Oh, is it my turn?
I can read if you'd like.
Go ahead.
Okay. A 53-year-old woman has experienced nausea with vomiting and early satiety for the past 7 months. On physical examination, she's afebrile and has no lymphadenopathy or hepatosplenomegaly. CBC shows hemoglobin 12.9, hematocrit of 41.9%. Nora. Platelets of 263,000, WBC of 8,430. Upper GI endoscopy shows loss of the rugal folds of the stomach over a 4 by 8 centimeter area of the fundus. Gastric biopsy specimens reveal presence of H. pylori in the mucus overlying superficial epithelial cells. There is mucosal and submucosal monomorphous infiltrates of small lymphocytes, which are CD19 and 20 positive, but CD3 negative. After treatment of H. pylori infection, her condition improves, which is the most likely diagnosis. No, don't say sorry. It's okay. It's just funny.
Like, she didn't even get to the H. pylori part before you answered. Anyone else have answers? Different answers? Kind of gave it away.
No one?
Wow. I know there's a lot of options.
And this question kind of rambles. There was a lot that they could have taken out, and it does not offer you anything. Okay, so since no one's answering,
5 more seconds. 4, 3, 2, 1.
Yeah, you're right. H. pylori gives it away like entirely.
It is a maltoma or marginal zone lymphoma. But now I want to ask, to those who didn't answer, why were you struggling with this question? So that we can explain it.
Were you struggling?
Or were you struggling? Sorry, I assumed you guys were struggling.
Or is it the fact that Noda said F and you guys were like, well, she's our spokesperson? If Noda says F, it's F.
Were you scared to answer because Iman yelled at Nora when she answered?
Sorry.
Because I just want to make sure that you guys actually understand this question. Because this is a high yield thing.
What if they all simultaneously got off their laptops at the same exact moment?
I trust Nora's answer.
Me too, Sarah. Me too.
It's yeah.
And Nora we trust.
Okay. So I guess to keep the conversation about maltomas flowing, how do you think they treated her maltoma? This is like my favorite thing in medicine.
And also very, very important high yield point. It's going to come in step 1 and 2.
Oh, nothing.
Come on, guys. Literally get it right.
It's a very broad, vague answer. Like, I'm just looking for like, how do you think they treat a maltoma? Like, what class of drugs do you think they use?
Is it imatinib? Okay, Noda, you're not on the wrong track. But before that.
Like, it's something super general. Think of the bacteria that they're infected with. Should I say it? I'm gonna say it. It's
okay, no. So metronidazole is one of the drugs.
Yeah,
so basically
more broad than metronidazole.
Yeah.
Like I'm thinking like super broad. It's antibiotics. I'm gonna say it. This is like my favorite fun fact in medicine. Like, this is a cancer that can be treated with antibiotics, like fully. So that's their fun fact of the day. Another high yield thing that you guys should know is that maltomas are caused by Helicobacter pylori, and they're like the only cancer that can be cured by antibiotics.
So malt lymphomas are a type of marginal zone lymphoma. You're going to notice if you look on AMBOS, if any of you do have AMBOS, under marginal zone lymphomas, there's multiple types. Malt is one of them. It is the only one that you can treat with antibiotics. Specifically, you're going to give these patients quadruple therapy. Okay, so quadruple therapy for H. pylori treatment. Okay, usually when you give that regimen for H. pylori, their maltoma will go away. If it does not go away, then you start treating with chemotherapy or radiation therapy, whatever is indicated in that patient. And that you guys don't even need to know at your stage, but you can know that one of the things that you can give for a maltoma are tyrosine kinase inhibitors. So that's why Noda, like, yes, you're correct. You can give imatinib, but it is not the first line treatment at all. You have to first make sure that they, like they're infected with H. pylori, and then you give them antibiotics, quadruple therapy, because it's a lot less, like, I guess, chemically invasive, in my opinion, than a tyrosine kinase inhibitor, which you're giving for cancers. Okay.
All right.
So I took this directly off of AMBOS. So that's all you need to know. Literally, it's associated with H. pylori, but you guys know.
Moving on.
Yeah.
33-year-old woman reports having generalized fatigue and night sweats for 3 months. A physical examination shows non-tender right cervical lymphadenopathy. Biopsy of one lymph node shows a microscopic pattern of thick bands of fibrous connective tissue with intervening lymphocytes, plasma cells, eosinophils, macrophages, and occasional Reed-Sternberg cells. An abdominal CT scan and bone marrow biopsy specimen shows no abnormalities. Which of the following is a likely subtype of... Oh my God, I just stopped reading. Which of the following... Where am I? Which of the following is the most likely subtype and stage of this patient's disease?
Okay, so
Okay.
you guys are saying C.
Yeah.
Anyone else have a different answer? Okay, C. One more person answer.
Yeah, please. My back.
C. Okay. All right, so you guys are correct. It is C, nodular sclerosis, stage 1. So why do you say stage 1? What is the hint for stage 1?
The hint is in the question. Yes.
One lymph node on one side of the diaphragm. Perfect.
Yeah.
Perfect. Good job. That's exactly what I was looking for. All right, nodular sclerosis. Nodular sclerosis. This is what it's going to look like. So
It's the most common subtype of Hodgkin's lymphoma also. So just if they ever ask you like what's the most common subtype, or usually it's the answer.
Yeah.
Next question.
All right, so a 9-year-old otherwise healthy girl has complained of pain in her right armpit for the past week. Examination by the physician shows tender lymphadenopathy of the right axillary region. There are 4 linear and nearly healed abrasions over a 3 by 2 centimeter area of the distal ventral aspect of the right forearm, and single 0.5 centimeter slightly raised erythematous nodule over one of the abrasions. No other abnormalities are noted. If a lymph node biopsy were to be performed, the microscopic appearance of the specimen would show a pattern of stellate necrotizing granulomas. The lymphadenopathy regresses over the next 2 months. Infection with which of the following is most likely to have produced these findings? A. Bartonella henselae, B. Cytomegalovirus, C. Epstein-Barr virus, D. Staph aureus, or E. Yersinia pestis. Okay, so you guys have already said A. Does anybody else have a
What does she have? What does this girl have?
Cat scratch disease.
disease.
Nice.
Yeah.
Okay, good.
Good job. Yeah, so she was infected with Bartonella henselae. The cat scratch disease pattern is the stellate granulomas. Like that's like your key, like histological like description for cat scratch disease.
They actually might bring that as a question, by the way, instead of asking you which like pathogen or what is the cause. They might ask you like, what? Okay, so this person has these. They're not going to tell you they have cat scratch, but they're going to say the same thing. Right axillary, whatever. They have healed abrasions. They have a raised nodule over one of the abrasions. Which of the following histological pattern is going to be present in this patient? Then one of your options can be stellate necrotizing granulomas, and that would be your answer. They can give you other things to try and throw you off, but you can remember this way. All right.
All right.
Oh yeah, so over here you can see the cat scratch, like the cat scratches on the dorsum of the hand. You can see the axillary lymphadenopathy. Those are the 2 main things that they're always going to mention in cat scratch disease.
All right.
Okay.
A 78-year-old man presents with increasing fatigue. CBC shows pancytopenia with moderate anemia, hemoglobin 10.5, and normochromic, hypochromic RBCs. Mild neutropenia and thrombocytopenia are noted. A bone marrow evaluation reveals erythroid hyperplasia with increased iron. A Prussian blue stained bone marrow aspirate is shown in the image. Which of the following is the appropriate diagnosis? I'm biased to this question.
Ooh.
Yeah, we got them.
Ooh.
We got
I
you
like
guys.
this question.
We got you guys. You got you guys.
Okay. So Riyuf said E, Nof said C, Sara said E, Nora said C.
I can
Those are my
see,
initials.
yeah, I can
EC.
see how this could be a very confusing question.
I was confused when I was writing it, to be fair. So
Yeah. Well,
one more person answer. See, interesting. Okay.
actually, it's multiple myeloma.
Yeah.
The reason I'm biased to this question is because I spent my summer doing research on multiple myeloma. But this is what multiple myeloma looks like. So you have the ringed sideroblasts, which are here. And ringed sideroblasts shown in the bone marrow is sort of the iron stippling around the nucleus of the cells in the bone marrow. And so this is going to point you towards multiple myeloma. Another thing that's going to point you towards multiple myeloma is the 78-year-old man. It's a disease of the elderly. You also are going to have pancytopenia because it's basically due to failure of bone marrow. And we're going to talk more about multiple myeloma in a bit. But this, honestly, I'll be honest with you guys, I feel like this question's a little bit too difficult, and also not going to be asked on your exam. Multiple myeloma is very low yield, but
It may come though.
there's no crab. I know there's no crab. Multiple myeloma doesn't always have crab, and they don't always have to say it. This could be an early version, like, of the disease. Like, it's not required that they give you every single part of the question. They can just give you enough. Like for here, the picture was supposed to be enough for you to understand that it's multiple myeloma. Do you get what I mean? So
if you see this picture, just know immediately multiple myeloma.
Just think
Look at the different size plasma cells. That's like usually a big giveaway.
Okay, next question. Unless you guys are still confused about multiple myeloma.
Do you guys have any questions about the previous? Doesn't myelodysplastic syndrome have sideroblasts too?
Can it? I don't think so.
I actually don't remember. Give me 1 second. Let's look at it together really quickly. Okay, it's not loading.
It can, but again, the reason I want, like, this question pushes you more towards multiple myeloma is the different sized plasma cells in the bone marrow. So you can see like this abnormally large cell, and on top of that, the ringed sideroblast, and the age of the patient, and the vague symptoms, and the pancytopenia.
So Nora, one thing you said, the cytopenia. I'm glad that you brought this up because this is a very important point, and I think it's very important to remember. Anything that is invading your bone marrow, it doesn't even have to be a hematologic malignancy. It could be any malignancy. It could be a virus, whatever, can cause cytopenia, right? So you're right, cytopenia can occur in the other things, but that is not going to be your giveaway that it's multiple myeloma. Over here, it's the picture. It is confusing. I think this is a bit more, this is definitely confusing, like it's, it can be multiple things. If you guys all answer, for example, myelodysplastic syndrome or promyelocytic leukemia,
they would appeal and accept the answers.
Yeah.
I'm sorry, I brought this question because I like multiple
myelocytic leukemia, okay? Because those do not look like
or rods.
Our rods, yeah.
I would appeal this. I'm sorry, I just am really interested in multiple myeloma, and I like this question.
You guys will probably get a question on multiple myeloma, and it might be like this. So just like be prepared. Different size plasma cells, and yeah, old age.
And ringed sideroblasts. Okay.
Yeah, old age. Okay, 40-year-old woman complains of fatigue and nausea of 3 months in duration. Physical exam reveals numerous pustules on the face as well as splenomegaly and hepatomegaly. Lab shows hemoglobin of 6.3, platelets of 50,000. Peripheral smear shows malignant cells with our rods. Patient develops diffuse purpura, bleeding from the gums. We literally just talked about this.
We shouldn't have said that.
And lab features of disseminated intravascular coagulation, DIC. Which of the following is the most appropriate diagnosis? No way.
Yeah.
Good job, guys. Yeah.
Okay, no, but now we're gonna make it a little bit harder.
Yeah. How do you treat this?
No. What's the chromosomal translocation? I don't know how to treat it. No, I do. Sorry. What's the chromosomal translocation? What receptor is affected? And how do you treat it?
I mentioned all these 3 things earlier, so you guys should remember it. RARA. Okay. Yeah.
What is?
Yeah, no, she's right. Retinoic,
Oh, okay. I've never seen it
retinoic
abbreviated.
acid receptor alpha. RARA?
Rara,
That's
I've
all they
never
say,
seen
your PMO.
I've never, I don't know, I never clicked in my head. Atra
Atra
treatment,
treatment.
yeah.
Great. What is Atra? You guys do need to know. You guys, yeah, all transfer. Good job.
Okay.
Fun fact, by the way, guys. And a lot of DIC patients, especially in KFSH, because it is a tertiary care hospital, a lot of the patients do have cancer. When a patient presents with DIC, they will usually immediately give Atra anyway, even if they don't confirm that they have promyelocytic leukemia, and then they will stop it as soon as they know that they don't have it. Otherwise, they continue it.
So very fun. 1517, yes. Basically the main takeaway from this question is the R rods. You're like 1,000% gonna get a picture of R rods in your exam, whether that be in the OSPI or in the MCQs. You're gonna have an APML question, so recognize APML. The second thing I like that we thought was like important from this question was the DIC, because a lot of patients with APML present to the clinic with DIC and then get diagnosed with APML. So if you see a patient or like a case and a patient presenting with DIC, you should think about APML, just like what Eman said. And no, and at KFSH, they immediately give them the Atra.
Yeah, even if they don't confirm that they have APML, they just give you Atra immediately, and then they'll stop it if they know for sure you don't have APML.
All right. 55-year-old man complains of fatigue in his, oh my God. Complains of pain in his back, fatigue, and occasional confusion. He admits to polyuria and polydipsia. An X-ray examination reveals numerous lytic lesions in the lumbar vertebral bodies. Laboratory studies disclose hypoalbuminemia, mild anemia, and thrombocytopenia. A monoclonal immunoglobulin peak is demonstrated by serum electrophoresis. Urinalysis shows 4+ proteinuria. A bone marrow biopsy discloses foci of plasma cells, which account for 18% of all hematopoietic cells. What is the appropriate diagnosis?
This is a bit more.
Don't give it away. Don't give it away. Don't give it away.
I'm not saying anything.
You're gonna say this is a bit more clear, and then they're gonna think, "Oh my God, what did we talk about was unclear," and then they're gonna know the answer. D.
Anyone else have a different answer?
Someone choose Waldenstrom's.
Yeah.
Another D. Okay. Yay!
So I want someone to answer and say, give me 3 things in this question that tell you immediately. Okay, 4 things. In addition to lytic lesions, give me 3 things. That immediately tell you this is multiple myeloma.
Plasma cell.
Okay.
Monoclonal
Good.
peak. Yeah.
Okay, so these are 3. Give me another one. There's a more like obvious presentation. Actually, it's not necessarily obvious. It can be caused by multiple things, but especially because of his age. Back pain.
Yeah.
Great. That's what I was looking for. Back pain. So in elderly patients, if they have back pain, one thing that you want to keep in your differential, along with like disc herniation, the more common stuff is this could be multiple myeloma. Typically, like you want to keep it in mind because they might not have a fever, they might not have the other symptoms that you might have with a hematologic malignancy. You want to keep it in mind. Okay, so if you rule out everything else, then you can go in and, for example, do a bone marrow aspirate.
Yeah, they'll get pathological fractures without realizing it in their lower vertebra, and then they'll have severe back pain for a really long time because their bone marrow is super weak due to all the plasma cells proliferating in it. Okay. This is a classic multiple myeloma question. This has all the crap criteria. If you're going to get a multiple myeloma question in the exam, it's going to look more like this. I hope we're happy about multiple myeloma now.
Do you guys have any questions? I'm going to take that as a no. Okay. All good. Great. Okay. You want to read?
No, you are.
Okay. 9-year-old girl develops widespread pinpoint skin hemorrhages. She recovered from a flu-like illness 1 week earlier. Lab findings reveal a platelet count of 20,000, but no other abnormalities. Her bone marrow shows an increased number of megakaryocytes. Platelet count is normal after 2 months. Which of the following is the appropriate diagnosis? A. Antiphospholipid antibody syndrome. B. Disseminated intravascular coagulation. C. Hemolytic uremic syndrome. D, idiopathic thrombocytopenic purpura. E, thrombotic thrombocytopenic purpura.
D. 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 One more. D.
Okay, nice.
Congratulations.
Okay, where would you see antiphospholipid antibody syndrome? What would the case look more like?
Yes.
Multiple abortions, so adult female with multiple abortions. Yes, good job. Okay.
Wait, what's the target? This is a question that can come in your SAQs. What do the antiphospholipid antibodies target? I wrote this in the notes somewhere, I think.
Let me do it. It's not there. I just saw it. Where did you put it? No, you didn't write that, but you wrote the other thing.
Okay, did anyone respond?
By the way, I don't think that they're gonna get this in the exam.
I remember getting a
In renal.
antiphospholipid antibody.
No,
This?
Mm.
We did get it.
the HLS.
Yeah.
Crazy.
Let's go see the replies. Yes. Oh, okay.
There you go.
Good job. I think we were late to respond. Good job. Yes, these are the three things that the antiphospholipid antibodies can target. This could be very easy SAQ, like just very easy. What's being targeted by these antibodies? They'll give you a case of a woman, age of fertility, multiple abortions, the vita reticularis, everything, and then they'll say what can be targeted.
We'll put this in the notes below the slide before we send it to you.
A little bit about ITP. So basically what it's caused by is the autoimmune antibodies that coat platelets, and then they cause them to be removed by the spleen. Usually acute ITP is going to be seen in children. So you saw in this case that we had a child. Usually 3 weeks. Here it was 1 week, doesn't really matter, after a viral infection. And the bone marrow is going to show an increased number of megakaryocytes. And then the reason for this is because the body is trying to adapt to the decrease of numbers of platelets that are being removed by the spleen by pushing out more platelets and thus having more megakaryocytes in the bone marrow. So the child will have purpura and petechia. And then here's just like a simple diagram showing, there is less platelets in ITP. All right. Okay, a 25-year-old. Wait, everyone gets ITP, right? Okay. 25-year-old previously healthy woman develops spontaneous vaginal bleeding, and the following day she experiences a tonic-clonic seizure. On physical exam, she is febrile and jaundiced and has widespread purpura. Laboratory findings include a hemoglobin of 5.3 with 8% reticulocytes and a platelet count of 10,000 and a blood urea nitrogen of 48. The peripheral blood smear is shown in the image. Oh, I didn't put the picture. Which of the following is the appropriate diagnosis? Hold on. I don't want to leave the thing because I don't know if I put the image. Sorry, you guys. I forgot to put the blood smear.
I want to share my screen, but they're gonna see my search.
It's fine. You don't really need the blood smear, I feel. It's not super characteristic.
Yeah.
D. And what else? Yeah.
Okay.
Yeah. You guys didn't even need the blood smear.
Yeah.
This
What would you see on a blood smear?
What would you see on a blood smear?
Schistocytes, good.
Yeah. What else? While you guys are thinking, let's keep going. So yes, this is TTP. Basically, actually, no, I showed the answer. Can you guys tell me what you think TTP is? What's the pathophysiology of TTP? Adam TS13 mutation. Perfect. Yeah. So TTP is again like an Adam TS13 mutation. So basically, the function of Adam TS13, which has a really weird name, is to cleave von Willebrand factor to prevent it from being like the super long von Willebrand factor that can have a bunch of platelets to aggregate. But if there's a mutation in the Adam TS13, then they're going to have a bunch of the von Willebrand factor is not going to be cleaved, and you're going to have all of these aggregations. Also, there is a pentat for TTP that was kind of seen in this question. So you have neurological problems, you have fever, you have thrombocytopenia, you have microangiopathic hemolytic anemia, which is going to show those cystocytes, and you have acute renal failure. And so here we saw a lot of these things. We saw the neurological problems, we saw the fever, we saw the thrombocytopenia, we saw the acute renal failure. So like those things should always push you towards TTP. And that's it.
They actually used to teach us TTP in our renal block, literally simply because of this. I didn't actually know that they put it in your guys' HLS block. Heme block, I mean, sorry.
All right. This is a really easy one.
Okay, so
Answer before Iman can read.
4-year-old boy, severe bleeding into the knee joint. Lab studies show serum levels of factor 9 are reduced, but factor 8 is normal, which is the appropriate diagnosis. I'll beat you.
This is a year one question. This is a year one question.
Great. Okay, so B.
And you're right. It is hemophilia B. Hemophilia, high yield, easy thing for them to ask you. Hemophilia A is the factor 8 deficiency. Hemophilia B is the factor 9 deficiency. Their APTT will be increased in both. And then the treatment is either you give them factor 8 or you give them factor 9. It's really like basic. I don't recall getting a hemophilia question in third year, but it's taught, so you may get it. But this is just to make sure you're able to differentiate the two from each other. Next question.
Okay, do you want me to read?
Yes.
4-year-old boy has appeared listless for about 1 week. He now complains of pain when he is picked up by his mother. He exhibits irritability when his arms or legs are touched. In the past 2 days, several large ecchymoses have appeared on the right thigh and left shoulder. CBC shows a hemoglobin of 10.2, hematocrit 30.5, MCV 96, platelet count of 45,000, and a WBC count of 13,990. Examination of the peripheral blood smear shows blasts that lack peroxidase positive granules but contain PAS positive aggregates and stain positively for TDT. Flow cytometry shows the phenotype of blasts to be, oh, you guys beat me, to be CD19 positive, CD3 negative, and SIG negative. Which of the following is the most likely diagnosis? So we have E.
It's all E.
Nice.
Why is it E? You're right, it is E, but why is it E?
Nice,
TDT
TDT.
positive.
That was
Yeah.
the biggest giveaway.
Yeah.
Also, oh, never mind. That's not a giveaway. I was gonna say CD19, CD3 negative, but that's not necessarily the case.
It
AML
still
is
points
just
you
acute
towards
acidic.
T cells, so you can
No, it's not T cells.
B
BCL.
cell. It still points you towards B cells. So sorry, I missed it. Back with this picture, because I'm serious, you guys. It's so important. You have to learn this. Like I'm not kidding. This is really important. I hope the emphasis that it came twice makes it click for you guys that this is serious.
Not just in hemonc. It comes in a lot of other things
Yeah.
which are important for here as well. So yeah.
57-year-old lady presented to the clinic with increasing fatigue. On physical examination, she had a palpable non-tender axillary and inguinal lymph nodes, and the spleen tip was palpable. A lab study shows hemoglobin of 10.1, hematocrit of 30.5, MCV of 90, platelet count of 89,000, and WBC count of 31,300. From the peripheral blood shown in the picture, which of the following is the most likely diagnosis?
What do you guys see in the blood smear?
This could be a hard question.
Nice.
okay.
Note off his smudge cells. It's pretty straightforward in my opinion. Now, do you guys know how smudge cells happen?
I don't think they know.
Okay, basically when they're so smudge cells are not there like in your body, but when they take your blood and then they put it under the slide. When they put the slide on, that's actually causing the lymphocytes to, what's the word?
To break. They basically
yeah.
break. Yeah. Their lymphocytes get super weak in CLL. It's correct. This is CLL. And smudge cells is the characteristic like thing in CLL. And basically your lymphocytes get super weak that when they put it on the slide, it like ruptures them and then they become smudge cells.
Is that clear? Great. So consider CLL a disease of like the middle-aged or elderly. You won't see this in the pediatric population or like, in kids. If you get a kid in the question, don't assume it's CLL.
Okay, next question. What unique marker is expressed by this disease? I don't know. CD5. Correct, it's CD5. Why is that a unique marker? Like, why am I saying this is a unique marker? It is T cell. What is T cell? I knew, but I forgot. So CLL is a disease, is a B cell leukemia, but CD5 is a T cell marker. So you're not supposed to see T cell markers in B cell leukemias, but for some reason in CLL, it's positive for CD5. So that's one thing that might confuse you in the CD markers. So make sure that you remember that CLL is the one B cell leukemia that is positive for a T cell marker, which is CD5. Okay, so some things about CLL quickly. It's a B cell malignancy, like we already mentioned. It's the most common leukemia in elderly people, according to AMBOS. It is more common in men. It's usually asymptomatic, but they could have painless lymphadenopathy, they could have fatigue, they could have pruritus, and more susceptibility to infections, which is basically the presentation of every leukemia. Smudge cells, because their lymphocytes are rupturing really easily, and then that's expressing CD5, 19, 20, 23. So 19, 20, 23 are B cell markers. That makes sense. CD5 is a T cell marker. That's the unique thing.
Guys, if you are having B cell, like an increase in number in B cells, which are responsible for creating, your antibodies and stuff, why do you think there's increased susceptibility to infections if you guys are having like increased B cells or increased immune cells in general, increased leukocytes? What's the reason? Clonality. Okay. Simpler reasoning.
I guess.
Sure.
It's because they just don't work.
But why?
Because they're not being built properly.
Because they're immature.
Yeah.
That's it. It's just because they're immature. So especially in acute leukemias, you have increased immature cells. So immature cells are not made to create antibodies. They have to mature in order to create antibodies. All right, is that clear?
All right. A 45-year-old woman has experienced malaise with nausea and vomiting for 3 months. On physical examination, she has scleral icterus and yellowish hue to her skin. She has difficulty remembering 3 objects after 3 minutes. There are no neurological deficits. Laboratory study shows a positive serological test. result for hepatitis C and serum ALT of 310, AST of 275, total bilirubin of 7.6, direct bilirubin of 5.8, ALP of 75, ammonia of 55. An abnormal result of which of the following laboratory studies of hemostatic function is likely to be reported? All right, this question, the answer is simple. The question itself is going to make you think a little bit, to me. What do you guys think? What are we feeling, you guys?
Okay, so we got one B, we've got one E. One D.
Bad.
Okay, so one more and then we'll explain.
Everybody just answer the other two options and then one of you will be right. We did this in the clinic. One more answer, you guys. One more answer.
Somebody say C. Thank
Yes,
you,
and C. Okay.
Okay.
So this is crazy. I don't know why I said that. Sorry. I'm so scatterbrained right now. What I want you guys to know from this is that she has hepatitis C. Where are clotting factors made?
In the liver, good. Okay.
And where does hepatitis C infect? Hepatitis C infect or B.
The liver. Great. Nice. Okay.
And boom, there you guys down it. I don't know what I'm sorry, I was distracted. Yes, so this question is a little bit confusing. It's a very simple concept in the fact that clotting factors are made in the liver, but we didn't tell you exactly that the liver is messed up. But what I want you guys to take away from here is that you're still going to be asked year one heme onc questions because there are a couple of year one lectures in heme onc. I don't know if you guys remember that. Like, there's still like basics of hemostasis, stuff like that. So make sure you guys go over that because they're really simple concepts, but you will get questions sort of similar to this asked in your exam. Like, I think we had around 3 to 4 questions, stuff like this. So it's prothrombin time. Their clotting factors are not doing well, which means they're unable to have a proper prothrombin time. It'll be prolonged. So we got that right. Sorry, I was so scatterbrained during this question. But we're good with understanding this. Yeah, okay. And oh, this is a little fun thing I wanted to put for you guys. How will von Willebrand disease present? I'm thinking more, by the way, I want more like lab based answers. Increased bleeding time. That's exactly what I was looking for. Increased bleeding time and what though? Regarding the platelet count. PTT could be increased, it could be normal. But how does the platelet count look in von Willebrand disease? Normal, exactly. So that's like a key thing that I want you guys to remember is that in von Willebrand disease, you're going to have an increased bleeding time and a normal platelet count. That's a very easy question for them to get.
Because you brought that up, just remember one thing. Platelets are made by the liver. Your red blood cells are made in your bone marrow, but platelets are not made by the liver. Sorry, thrombopoietin. Sorry, thrombopoietin comes from the liver. Erythropoietin comes from the kidney. Okay, everything's made in the bone marrow. Platelets come from megakaryocytes, which are in the bone marrow, but your thrombopoietin comes from the liver, and your erythropoietin comes from the kidney. So when you have chronic kidney disease, you'll see that these people also have anemia, not just like anemia of chronic disease, but also because they have less erythropoietin. Okay, That's an important thing to remember. What else?
I have more like rapid fire. Just I want you guys to remember stuff. Someone in the chat tell me what Bernard Solier is, and someone in the chat tell me what Glanzmann thrombasthenia is. Like, tell me what's the pathophysiology, very simply, of those two things. Just to make sure, like these four things are the things you're gonna get asked about from your first year stuff. So I want to make sure you guys know it. GP1B Bernard.
Lipoprotein 2B3A and Glanzmann. Nice.
Yeah, perfect. So make sure that you guys are aware of what's in Bernard and what's in Glanzmann.
So what is that an issue in?
Oh.
Which of these following options from this question, what would the answer be? If you said like, okay, this patient has Bernard Soulier or Glanzmann thrombasthenia, what is that an issue in? E, nice,
exactly.
perfect.
So
Platelet aggregation.
Aggregation, perfect. Okay, no, you guys got it. So those are the style of questions of the first year style questions from the lectures that you had in first year that you're gonna get in Eman. Everyone's least favorite type of question, table question. 45-year-old man with, do you want to read it actually?
Go ahead.
45-year-old man with an artificial heart valve is given Coumadin or warfarin to prevent the formation of thrombi on his artificial valve. Which combination of laboratory results is most likely to be associated with this individual?
Answer, and we're gonna break it down. I love these questions so much.
I hate table questions.
When you guys start studying for step 1, there are so many table questions.
There's a lot. You can see my UWorld tab open. There's a lot. Also, at the end of this PAL session, I'll give you guys a surprise. I'll show you guys a surprise. Because we're all doing very well and staying focused. Only if you get this question right, though. Oh, wow. Warfarin was in CVP.
Oh, okay, well then you guys should know it.
Yeah, you should know it. Also, like, let's just remember this is actually a first year concept.
Yeah.
About something that warfarin does to lab values.
So try to remember. Yeah, okay, good. Vitamin K. So what is vitamin K needed for? Name the enzyme. Name the enzyme vitamin K is needed for. Or is a substrate of.
We're dipping into pharmacology.
And we will.
And departments.
Okay, so if you guys don't know it, it is epoxide reductase, which is in your liver. Epoxide reductase reduces vitamin K in order to create which factors and which components of hemostasis. What do you guys think or remember? Come on, guys. You know this. It just happened.
Oh, did the Wi-Fi disconnect? I'm getting any. Like, wait, hold on. Oops, data appears. Can you guys? Okay, they said factors 2, 7, 8, 9. Factors 2, 7, 8, 9, 10. Can you guys hear us, by the way? Because the Wi-Fi and Iman's laptop disconnected.
Okay.
Yeah. Okay. Oops, I showed the answer. No, they didn't even get it.
Wait.
They're talking about the factors, the vitamin K factors.
Yeah. 19. I like to remember it 1972. So 10972 and protein CNS. Correct. Correct. Okay, Casada used, yeah, good. You corrected yourself. So not 8. 1972 CS. Okay. 19 is like not 19, it's 10-9. Okay, so 10 plus 9. Okay, so if you know that and you know that factor 7 is in which one?
Since
Extrinsic or
7.
intrinsic? Nice. Okay, so
Yeah,
since factor
PT
7 is affected, PT is prolonged. Now 10972, so 10, 9, and 2, and protein CNS. I know it's a challenging question, guys. It's okay. These table questions are always a bit challenging.
But I'm actually really glad that we brought this because This
It's an
is one
important
of
concept.
it's an important concept, and this is like a basic that we need to make sure that you guys know. Extrinsic. So factor 7 is for the extrinsic pathway. The remainders of those, the 2, 7, 9, are in the common pathway. So now that we know that factor 7 is in the extrinsic pathway, and that PT is for the extrinsic pathway, and that
I thought you were gonna click the answer.
And that warfarin is gonna act on vitamin K. Let's start thinking. Yani,
now, what about, for example, okay, forget about PTT for a second. Platelet count, is that going to be affected?
by warfarin.
No,
No,
good,
exactly.
because thrombopoietin comes from the liver, but warfarin has no effect on thrombopoietin at all. So your platelet count is going to stay the same, whether it's high, whether it's low, whether it's normal. Now, the bleeding time.
Yep, it should also be normal, correct. So knowing what we know now, what would we say the answer for this question is without having seen the answer, since I already exposed it?
We know that PTT is like factor 8. So factor 8 is there, for example. And there's other factors that are not mentioned that come from the liver or that are not affected by vitamin K not being reduced.
Only
Good,
PT
only
is prolonged.
So everything else will be normal.
So the answer is perhaps.
Perhaps D, maybe.
Perhaps.
Maybe.
Say perhaps on your
It's
exam.
a stretch.
Perhaps D. I like that. What else? Anyone? Any other answers?
Perhaps D.
Perhaps. I'm gonna say that in the clinic. I'm gonna say
perhaps Eman.
We already saw it. Okay. Way to keep it blunt. It is D. But let's talk about this like seriously. This concept is extremely high yield about warfarin and heparin and what they prolong in the coagulation profile lab like test. So PT is going to prolong warfarin is going to prolong PT. Heparin is going to prolong PTT. Another Ibrahim mnemonic is coming. PT, I remember it as play tennis. You play tennis outside. Outside is extrinsic. So PT is for the extrinsic pathway. PTT is play table tennis. You play table tennis inside. So PTT is for the intrinsic pathway. Heparin, IN, intrinsic, PTT. Warfarin, wars are fought outside, PT. Did that make any sense?
Wars are fought outside, you play tennis outside.
Yes.
Simple.
Perhaps. Okay, good.
Maybe.
So I actually but seriously, you guys, I want you to remember this because oddly, yes.
That's a new one.
I want you guys to remember this because it's very high yield that warfarin will prolong the PT and heparin will prolong the PTT, and there's most likely going to be a question about that. And it's important because you might get a patient that you're looking at their coagulation profile and you're going to see, oh my God, their PT is really prolonged. And you're going to start freaking out thinking, okay, what's wrong with this person? And at the end of the day, it's just that they're on a medication that was prescribed to them. So you have to know that PT can prolong the thing. And then warfarin, again, is not going to affect anything else. It's not going to affect the bleeding time. The patient is on this because their bleeding time needs to be normal. It's not going to affect their platelet count, and it's not going to affect their PTT because we said that the vitamin K dependent clotting factors are in the common pathway and in the extrinsic pathway. So that's for this question. Do we all understand this? Yes. Okay, moving on.
There's more.
There's a few more questions. We're reaching the end. A 60-year-old man comes to the office because of an 8-month history of cough, night sweats, shortness of breath, and fatigue. He also had a 9-kilogram weight loss during this time. He appears pale, and abdominal examination shows hepatosplenomegaly. His leukocyte count is 80,000, and his leukocyte alkaline phosphatase is increased. A peripheral blood smear shows 82% neutrophils with band forms and immature and mature neutrophil precursors. An X-ray of the chest ray shows a 9-millimeter right hilar nodule. Which of the following is the most likely cause of this patient's laboratory findings? A.
Hmm. Okay, what else? Other options?
I'm glad that these like last couple of questions are actually stumping you guys. Not that I want you guys to like not know it, but I'm glad that we're covering them. Because I honestly thought that these questions at the end might have been too easy. A. Okay, one more person. Yeah. So you're seeing a leukemoid reaction. So those who answered, can you tell me what's in this question stem is pointing for this to be a leukemoid reaction or pointing this? Yeah. Why do you think this is a leukemoid reaction?
Leukocyte alkaline phosphatase increased.
Yeah.
Nice.
Leukocytes greater than 50,000. Yeah.
Amazing.
Actually, those are basically the only two things that are super high yield. Yeah, you guys got it.
Okay, so next question. 2 days after admission to the hospital for treatment of acute myelogenous leukemia, AML, a 35-year-old man develops nausea, vomiting, fatigue, and muscle cramps. He has a history of diet-controlled type 2 diabetes mellitus. He has smoked 1 pack of cigarettes daily for 15 years and reports occasionally using marijuana. His temperature is 38.7, pulse is 85, respirations are 25 per minute, and blood pressure is 110/65. Lab studies are shown. Which of the following would have been the most effective in preventing this patient's current symptoms? So let's look at his lab. So his leukocytes are 16, hemoglobin is 13, platelet is normal. Serum sodium is 136. I think that's normal. Potassium is 5.9, upper limit of normal. CL 101, urea nitrogen, uric acid.
His calcium is low, his phosphorus is high. I will give you guys those two clues. I'm sorry I didn't put the normal values, but his calcium is low, his phosphorus is high.
So what do you guys think?
So well, let's think it through. First, what is this patient having? He's having tumor lysis syndrome. Exactly. He's having tumor lysis syndrome. So after being treated for the AML, his tumor
It's lysing.
it's lysed, and then it released all of its constituents into the circulation. So knowing that this patient now is having tumor lysis syndrome, how do we want to treat?
Sorry, his potassium is high, not upper limit of normal.
His potassium is high. I think his sodium is also high.
Sodium is normal.
Oh. But how would you want to treat this patient? I know this is a little bit of a pharma thing, but
uric acid is high. So hyperuricemia, hyperkalemia, hypophosphatemia, D-allopurinol. Okay.
now, okay, and just I want you guys to remember what's the most hydrate. Nora, that was the key word that I'm looking for. Knowing that I just emphasized on hydration, what's the answer? What?
Notice
I
that
gave
just
it.
said hydration. What is the answer?
It is intravenous hydration. It is. I brought this because I remember when we were being taught about tumor lysis syndrome, one of the things that was emphasized to us how important hydration is for preventing tumor lysis syndrome. You need to keep the patient well hydrated. Rasburicase, I saw someone answer rasburicase. Rasburicase is a good preventative measure, like it's a prophylaxis that you could give to prevent tumor lysis syndrome, but it's not really like among like the first lines of things, nor is it like that important. More importantly, you have to make sure that this patient is hydrated, and then allopurinol for the hyperuricemia is also correct. But remember, where the question was asking what is most effective in preventing this from happening, not from like how are you going to treat it now that it's happened. So we want to prevent it. By preventing it, we're going to give hydration.
All right, so the answer is E, intravenous hydration.
And then just so you guys know your lab values, hyperkalemia, in tumor lysis syndrome, you're going to see hyperkalemia, you're going to see hyperuricemia, you're going to see hyperphosphatemia, and you're going to see hypocalcemia. Can anyone tell me why you're having hypocalcemia, but hyper of everything else?
I'm sorry, hyperphosphatemia, hypocalcemia. I said the opposite in them either.
It's secondary
Okay.
to phosphate binds with calcium.
Nice.
Exactly. Because they're having high levels of phosphate in the blood, it's going to bind to all the free calcium, and then it's going to cause hypocalcemia.
All right.
I think this is the last question or the second last. Huh? I think this is like the second last question. Which of the following red blood cell preparations will most significantly reduce the risk of transfusion-related cytomegalovirus?
Answer to the best of your ability, and then we'll say everything we want to say.
C.
Okay, so someone said C. Okay, Rashdan said C. Anyone? Okay.
D.
Sada said D. No one
D.
said C or D.
Perhaps
said
C or D.
D.
One more answer.
Oddly, C or D.
Oddly C or D.
Any other
Guesses?
C?
C,
Okay, so majority are
alright.
saying C. So let's see.
And a majority are correct.
Yeah. So over here, leukoreduction, you guys can think of it as a very simple, straightforward. As your first line of thinking is like, oh, leukocytes are implicated in infection. CMV is an infection. If you get rid of the leukocytes, you're going to get rid of like the reaction to the infection. Or you can think of CMV infects leukocytes. So if you leukoreduce, you're less likely to give them the actual CMV. Okay.
Yeah, this is for the blood banking lecture. Another reason I want to talk about this is just what about D? Irradiation?
You do give irradiated blood for certain things, but I'm not remembering what right now.
I'm checking. I don't remember what it's for. So irradiation is when you expose the blood to like low level like radiation to clear what's in it, but it's not necessarily going to get rid of the infection that's present in the leukocytes. It's more indicated for like cancers and other stuff like that because you don't want to be spreading those kinds of cells.
It's usually for patients who are getting stem cell transplants. You want to reduce the risk of graft versus host disease, which I'm sure you guys learned about.
Yeah.
That's when you would give irradiated blood.
And then someone said, doesn't it completely clear the bone marrow? That is true, but if we're just doing blood transfusions, are we going to completely clear like, you know, someone's bone marrow each time? Like, no.
You're only clearing the bone marrow when you want to give them a bone marrow transplant.
Yeah.
And even then, just because you clear their bone marrow, literally they're susceptible to every single infection on the planet, like every single one.
All right.
Great.
And then here some fun facts for blood banking. Know your RH types, know your ABO blood types, know the blood matching, who can donate what blood to who. This is a question that can be asked. This diagram shows it. Anyone who has like these little circles, that means blood can be donated to them. So O can donate to O, A can donate to, or A can receive O and A. Read the diagram.
O is the universal donor, A
is the universal acceptor. And then fun facts, like rapid things. Platelets are stored at 21 to 22 degrees for 5 days. Fresh frozen plasma is stored at -30 for 12 months. Whole blood is stored at 4 to 8 degrees for 35 days. All three of these things could be an MCQ, like easily. So just know the storage for blood and other products, because all of these could be a potential question that you don't want to miss out on. Another thing I want to talk about for the blood banking question is an SAQ that we got last year was list the types of infections that you could get from a blood transfusion. All right. And so we were asked to list 5 infections. But I believe in your slides, there were 5 infections listed. Make sure you guys memorize all those 5. We happened to get lucky because the question was not specific. And because the question was not specific, you could literally write anything infectious in the world and you could get it correct. But I feel like if they're going to give you this question, they're going to be more specific, looking for the 5 in your lecture. So check out the blood banking lecture, see what 5 infections you can get from blood banking. From the top of my head, it's like hepatitis B, hepatitis C, HIV, CMV, like those things.
Usually it's viral.
So, like, remember those. And then,
oh my goodness, there's more. I forgot how many we put, honestly.
I'm sorry, but we're covering all the lectures.
Okay, so do you want me to read?
Yeah.
2 weeks after undergoing allogeneic stem cell transplant for multiple myeloma, a 55-year-old man develops a severely pruritic rash, abdominal cramps, and profuse diarrhea. He appears lethargic. Physical examination shows yellow sclera. There is generalized maculopapular rash on his face, trunk, and lower extremities. The desquamation of both the serum alanine aminotransferase, or ALT, is 115. Serum AST is 97. And serum total bilirubin is 2.7. Which of the following is the most likely underlying cause of the patient's condition? A, donor T cells in the graft. B, newly formed anti-HLA antibodies. C, proliferating transplanted B cells. D, activated recipient T cells. Or E, preformed cytotoxic anti-HLA antibodies.
I'm like almost positive this is the last question, by the way. So
okay,
give
so
it your all.
Dan said A. You can check. It is the last question.
This is the last question, you guys. E.
Okay, so Noda said E. Preformed cytotoxic anti-HLA antibodies. Any other options? Okay, Nof said A.
I want 1 or 2 more answers,
yeah.
and then we'll reveal it.
2 more.
2 more.
There's 9 of you. I want, or there's 9 including us. I want
And
2
the
more of you to
host.
answer.
So there's 6 people. Please.
Oh, right. We'll make 3.
E.
Okay, another E.
Okay.
Okay, so majority actually said E. The answer is A. Donor T cells and the graft. So this is, we just mentioned it.
Well, what's happening in this patient?
Graft versus host disease. Nice.
Exactly.
Good job.
So actually, could someone in like simple words tell me what happens in graft versus host disease? Doesn't even have to be super medical. Cytokines released by T cells. Okay. What else? Donor T cells attack the recipient.
Perfect.
Exactly. That's verbatim what I was looking for.
Yeah.
I also didn't cover this custom. It's fine. That's why we're here to cover it. This is what's happening in graft versus host disease. So I have a little bit here. Basically, graft versus host disease, what's happening is that there's an immunological response in which the donor T cells, so the person who's donating the graft, recognizes the host as foreign. And so the host is receiving this donation, and then they're getting attacked by the donation in their body, and it's going to cause systemic inflammation. So graft versus host disease can be split into 2 categories. It could be acute, which is less than 100 days after transplant, and it can be chronic, which is more than 100 days after transplant. Now, you don't need to know the treatment, I feel, that importantly, but just know, graft versus host disease can affect a lot of different parts of the body. So it can affect the skin, it can affect the GI tract, it can affect the liver. In chronic graft versus host disease, you're going to see that the patients have like sort of like skin lesions and destructions around their eyes, around their mouth, around their joints, around their fascia. Like that, there's going to be more damage in the chronic thing. And then also in chronic graft versus host disease, they're going to have a lot of lung issues. So that's why the spirometry will be abnormal, because they'll have an obstructive lung disease. And you guys just did CVP, so you know what that is. So just make sure that you understand in graft versus host disease, the donor's T cells are attacking the recipient's tissue, as Noah put it. And that's it. We're done. We did it. All of Hem Onc Patho.
Feel free to contact us literally at any time. I know your guys' exam is in 2 days, but that is plenty of time, by the way, for any of you who are feeling nervous about any topic to, go over it again, to contact us and ask us questions. Genuinely, guys, do not freak out. Not HLS, I keep saying HLS.
Iman.
HEME in 3rd year, in my experience, and then I think even after that, has always been a pretty fair exam in terms of what they test you on. If I'm not wrong, it's Dr. Rayhan, who is the block director. He will only bring things that he asked you, or he teaches you guys. He will ask you about the things that he touches upon. Doesn't try to surprise you. Okay, so just keep your head up, go over, your practice questions, your past questions, whatever it is. You guys will be fine. Feel free to reach out.
We
give
will-
us feedback too.
We
Okay?
will stick around for like 5 minutes just to see if anyone has any questions, wants to ask anything. But I believe, thank you by the way to the host for recording
Yeah.
so much. I believe we're done. If you would like to stop recording.